Hello, my name is Marcella Wojcik. Working together with a friend and colleague, Dr. Laura Belair, we will present a short video on the topic of club feet. I am a pediatric orthopedist practicing at the University of Utah and Shriners in Salt Lake City, while Dr. Belair practices at the University of Wisconsin in Madison. Thank you so much for joining us. What exactly is a clubfoot? A clubfoot is usually easy to recognize at birth. More recently, club feet have also been identified on prenatal ultrasound screening, which affords families some time and opportunity to understand the diagnosis before birth. Clubfoot is also referred to as Talipes equinovarus. Some examples of club feet are shown here. One patient has a left clubfoot with a normal right foot. The second patient on the right has both or bilateral club feet. Notice that the foot is inverted and positioned facing the tibia or shin bone, with an appearance that somewhat resembles that of a golf club. A clubfoot has four components. The heel is turned in, which we call varus. The ankle and foot are pointed down, which we call equinus. There is a high arch, which we call cavus, and the forefoot faces inward, which we call adductus. Additionally, the foot and calf can be smaller on the affected side. This is more noticeable as the child gets older and is less evident when both feet are involved. A clubfoot must be differentiated from a postural clubfoot, as well as another deformity termed metatarsus adductus. A postural clubfoot easily corrects into a normal-appearing foot simply with stretching. Metatarsus adductus, which is shown here, is a deformity that involves only the forefoot, such that it looks similar to the shape of a kidney bean. It is also more flexible and correctable in comparison to a true clubfoot. This tends to get better on its own. Who gets a clubfoot? A clubfoot is congenital, which means it is present at birth. It is one of the most common birth defects, and certain populations have greater numbers of children with club feet, such as Hawaiians and Maoris. In the vast majority of cases, we describe a clubfoot as idiopathic. This means that there is not a specific reason it developed. 50% of patients have club feet on both sides. Boys are affected twice as commonly as girls. And in 25% of cases, club feet run in the family. Club feet, however, are not inherited the same way other conditions can be inherited. Multiple factors have been found to be involved. There is not a specific gene that results in the formation of a clubfoot. Some children have club feet that have other associated conditions, such as spina bifida or arthrogryposis. We may refer to these club feet as teratologic, and they can be more severe and more difficult to treat than typical or idiopathic club feet. Why do we treat a clubfoot? Simply stated, we want our patients to be able to walk, run, play, and have fully active lives. Club feet are not normal feet, however, so there are some differences in how these feet will function and appear in comparison to normal or unaffected feet. Left untreated, the patient will walk on the top and outside of the foot. This results in pain, significant limitations, and disability. How do we treat a clubfoot? Historically, we treated club feet with a major surgery called a PMR, or posterior medial release. Dr. Ignacio Ponsetti, seen here in the 1940s, was one of the first orthopedic surgeons to recognize that this common clubfoot surgery led to long-term issues with feet that were stiff and painful. He developed a non-surgical method to treat club feet, which has proven highly successful in creating normal-looking feet with normal function. We call this the Ponsetti method.
This is Laura Belair from the University of Wisconsin. I'll be taking over from Dr. Wojcik to talk a little bit more about the casting process. At your first appointment with your orthopedist, expect to have hard casts placed from your child's toes up to the top of their thighs. It can be helpful to feed your baby just before or during the casting process, as this can help them relax for the procedure. Each week, a new cast will be placed with the emphasis on correcting different components of the deformity. During this process, you will want to make sure that your baby's toes remain visible, warm, and pink. If the toes become white, cool, or slide up into the cast where they are no longer visible, the cast should be removed immediately. Most babies need a series of 5 to 7 casts, which are changed once per week. Once the foot is corrected except for the tight Achilles tendon, your infant will have a procedure called a tenotomy, where the tight tendon at the back of the ankle is released through a small incision. This can be done under local anesthetic in the office or under sedation in the operating room. Then a final cast is placed and remains in place for 3 weeks. After this final cast, your baby will be fitted with leather and plastic boots based on the size of their feet. Pay close attention to how these boots are fitted and make sure you are comfortable with how to put them on. There's a small window in the heel of the boot where you can check that your child's heel is seated down in the back of the boot, which means that the boot is on properly. Whether your child has one or both club feet, they will need to wear 2 boots with a bar between them to maintain the correction. Most children require 3 to 4 weeks of full-time wear of 23 hours per day. After this, time in braces decrease so that by the time your child begins standing, cruising, and taking steps, they are only wearing the brace during nights and naps, aiming for 12 to 14 hours per day. This part-time wear is then continued until 4 to 5 years of age. During bracing, your child will typically be seen every 3 to 6 months to assess the feet and also to upsize the boots as their feet grow. If their feet remain well corrected at the age of 4 to 5 years, bracing is typically discontinued at that time. There will still be follow-up on an annual or biannual basis, as some children can have late recurrence of their deformity or deformities. Even in the best circumstances, we know that about 20 to 30% of patients with clubfoot deformities will develop some degree of recurrence, and this requires another series of casts or sometimes a surgical procedure. Routine follow-up will allow these issues to be identified promptly, so treatment can be as successful and timely as possible. There are a variety of ways that clubfoot recurrence can take shape. One of the most common findings that can develop and require a procedure later in childhood is recurrence of the tight Achilles, or having one tendon that pulls the foot inward while your child is walking. This is something that can be seen on physical exam and does not require x-rays or other studies. Sometimes the recurrence can be more complex or atypical, and advanced imaging can be required. While clubfoot is most commonly seen without an underlying medical diagnosis, a severe or unusual recurrence can be a reason to do more advanced workup with lab assessments and consultation with other specialists. In the end, our goal in treating your child's clubfoot deformity is to achieve a supple, growing foot that is positioned ideally for standing, walking, and other activities. Many children with club feet go on to be great athletes and enjoy a variety of other activities without limitations. Treating club feet with casting has allowed us to avoid much more invasive surgery, which means less stiffness and less disruption of growth. It is, however, important to understand that having a clubfoot that is successfully treated does not guarantee that it will look or feel totally normal. Most patients with club feet will have slightly smaller foot size and calf muscles on that side. Still, it is unusual for this to have a long-term functional impact. Thank you for listening to our review of club feet. For additional information regarding this diagnosis or other common bone, muscle, and joint conditions in children, please visit orthokids.org.